It was an extraordinary year, 2025, at the Feinstein Institutes. It was absolutely extraordinary. We had celebrated advances in the science, and not only of the vagus nerve, but across many of our institutes. We celebrated major advances in health system science, in behavioral health. The list goes on with basic advances in immunology and neuroscience, and in the translation of scientific findings from the laboratory bench to the bedside. So all of us at the Feinstein Institute have enjoyed a fantastic year. Rheumatoid arthritis is a potentially devastating condition. It's an autoimmune disease that affects not only the joints with painful, red, swollen, tender joints, but can also affect other organs like the brain, the heart, the kidneys. And so people with rheumatoid arthritis are looking for solutions to reduce the amount of inflammation that is occurring because of this autoimmune disease. And they end up taking very powerful medications that suppress the immune system. So balancing the right amount of inflammation is critically important, not only to health, but to restoring health in patients with rheumatoid arthritis. The discoveries that we made many years ago at the Feinstein Institute laid the groundwork for something that happened this year, which was the culmination of literally decades of work that point to the fact that it's now possible to treat rheumatoid arthritis using a small device about the size of a Tylenol capsule that sits on the vagus nerve in your neck, which sends signals to stop inflammation. And it does this without causing immunosuppression. And so that's the breakthrough. The breakthrough is that this year the FDA approved the use of this device manufactured by a company called Setpoint Medical that we actually spun out of the Feinstein Institute in 2007. So there's a lot of excitement about this idea now. The idea we call bioelectronic medicine, because it's using essentially computerized nerve stimulating devices to control inflammation in patients. It's something that we all at Northwell and Feinstein are extraordinarily proud of and happy about, because we see a time when this work is going to benefit a lot of patients.
What is unique and important about psychosis is not just that it's associated with aggression and violence towards caregivers, but it heralds a more precipitous decline in cognition. People with psychosis progress more rapidly through the phases of Alzheimer's disease, and they die sooner. What we wanted to do was to identify neural networks that would help us to be able to predict which patients were going to eventually suffer from psychosis and Alzheimer's disease, and develop a quantifiable biomarker to be used in clinical trials to track response to treatment. Not only was the network established, but increased connectivity between what we call the network nodes means the regions of the brain that are degenerating in psychosis and Alzheimer's disease are talking more with each other, not less. That doesn't really happen in Alzheimer's disease. So the crosstalk, we think, between some of these regions, the motor cortex, the language cortex, it's driving kind of a false narrative, a confabulation around things like people are stealing, people are watching, people are trying to hurt me. When you recruit the motor cortex around that, that's when we think you get violence. So I think that it's important because when you're able to go beyond just identifying the fingerprint and create a quantitative marker for the expression of that fingerprint, you can absolutely translate that into a treatment target.
There's a lot of nuance when it comes to understanding our gun violence epidemic. That is what we've learned. The risk factors for the different types of gun violence, whether you're talking about mass shootings, unintentional or accidental injuries, public mass shootings, or interpersonal urban violence, are incredibly different. And hence, our solutions to the different types of gun violence have to be very, very different. So our screening protocol, for example, is one of the only ones in the country that asks questions about firearm access-related risk, but also violence-related risk if you live in a community where you're hearing gunshots all the time. the interventions are very different, right? The former has much more to do with safety, firearm safety, gun locks, and the latter has much more to do with violence intervention, improving socioeconomic standards, providing jobs. Those are actually the biggest risk factors for interpersonal firearm homicide in this country. And so that's really what we found. And through that approach, we've understood that when it comes to public health, you need all these interventions if you're going to tackle this epidemic. You can't just rely on one policy or another.
HIV is the pandemic before the pandemic that most people now remember, but is still ongoing. But what we were interested in, and I've been interested in this for some time, was the discovery that about 9% of our entire genetic complement is made up of fossil remnants of ancient infectious viruses, not very dissimilar from HIV. We found unexpectedly high levels of HERV activity. And there's another family of proteins, they're actually called crab-sing finger proteins. They're just like little crabs going around, and they normally lock onto these HERVs and stop them from doing what they need to do. But in this case, because the crabs had sort of buried underneath and gone to sleep, that these HERVs were active, and what these HERVs did was good. They actually prodded nearby genes to get to work, and those nearby genes turned out to be fantastic at stopping HIV replicate. If we could mobilize those crabs, if we could get the right crabs to go underground and have the right HERVs come up, then we could potentially use this in everyone as part of an HIV cure program. And so what we call this is learning from ancient viruses how to suppress the current virus problem from HIV. And we're making progress.
Isolated REM behavior disturbance means that you have a sleep disorder where all of your dreams are not being suppressed, so that you're having vivid dreams, but you're also moving in response to those dreams. But the big challenge is when. When will it be? So this research is really saying, what is the marker that you have that says this will develop into Parkinson's? What are the baseline risk factors in the image that are telling you how close or how far away you are from developing the symptoms? But it also showed us another thing, which is even those who weren't destined to have the disorder for some period of time already had abnormalities in the way the signaling in the brain was happening. And we tracked those people over time and found that it was not latent, that this had continued to get worse year by year as we studied them. So there's a lot of Parkinson's that's not visible to us as clinicians or as family members or as just colleagues and friends. How I was taught is you just wait till they develop their symptoms. But in today's world, we don't need to wait. We can try to go out there, clarify who's going to get what and when.